take it from there. Okay, so good evening again, everybody. Welcome again to the weekly webinar. Tonight, we're going to focus on an update on what's happening around different parts of the country. We've contributions from Cork, Limerick, Galway and Northern Ireland, which I think will be very, very interesting to see what's going on, and especially be able to see what's going on in two different jurisdictions would be very important. As always, keep your cameras on off and your microphones on mute. That way the sound is not interrupted and everybody can hear what's going on. The slides will be put up during each person's talk and will be available at the end of the webinar for everyone's information. And the webinar will also be recorded and put on the website for people who want to listen later if they haven't had a chance to join tonight. And as always, we will ask that you raise any questions using the chat function, which you'll see on the menu bar when you open up. So if you raise those questions either during the talk, the President or myself will deal with those during the question and answer sessions, which can be between the speakers or at the very end if there's anything else going on. So raise your comments or questions there. That'd be the best way to do it. And without any further delay, I'm going to ask that our President, Professor Ronan O'Connell, would introduce the guests and say a few words to set the scene. Thank you.
Well, good evening all. It is with some trepidation from Dublin that I speak to the rest of the provinces, as we're likely to be going to DEFCON 5 very soon, as far as I can see. The word is not good, and clearly social distancing is not a trait that the Dubliner has been adept at. It's very salutary, or was very salutary this morning. I was on a webinar with the Minister for Health, who was addressing key people around the country, and just the state of play in the health service now is really at a tipping point. And we've enjoyed, I suppose, the eye of the storm over July and August, but predictably, as schools open, universities open, I think the spread within the younger generation is beginning to spread now within families, and it'll only be a short period of time before we have the influx into the hospitals and into intensive care. As of this evening, as far as I know, there are 60 patients in the hospitals around the country with COVID, which is 10 times what it was 5 or 6 weeks ago, which is really worrying. And in the UK and in Great Britain, certainly this evening, it does seem that it's beginning to get out of hand as well. Nearly 4,000 new cases today in the United Kingdom. Interestingly, I was on a separate webinar. As you gather, I'm spending most of my time in this chair looking at a screen this afternoon with the advisory board to RCSI. And we had a contribution from a professor in Norway. And one of the biggest outbreaks they had there was in the University of Bergen, which all dated back to Freshers' Week. And the freshers didn't adhere to social distancing and guidance. And unfortunately, there's been a major outbreak of that. And so that's the way it's going to happen. It'll spread amongst those who are least likely to suffer from it, and then get into families, and then get into hospitals. And I guess that's what's going to happen. Already, we know that there's going to be pressures on scheduled care, and the first port of call whenever there's pressures on the hospital is elective surgery. And I'm afraid we're now going to run into that. So it'll be very interesting to hear from Cork, Limerick, Galway and Belfast as to how COVID is affecting you and what measures you're taking to try to anticipate this second surge. So Martin O'Sullivan, consultant breast surgeon in Cork University Hospital, is very kindly going to give us an update on what's happening in Cork.
Okay, thank you, Ronan, and thank you all for listening. First slide, please. So I work with BreastCheck, and I work in CUH and also in the Bon Secours Hospital in Cork. Next slide. So just for those of you who might not be familiar with how things are in Cork currently following reconfiguration, there are 3 public hospitals in the city. Cork University Hospital is the largest and is the designated trauma centre, and is also the designated cancer centre for the region. There are 2 voluntary hospitals in the city, the Mercy University Hospital and the South Infirmary Victoria University Hospital. The South Infirmary predominantly does elective work, and there is no acute emergency department open for the past 5 or 6 years. There are 2 other hospitals in the region, Bantry and Mallow. From a surgical viewpoint, they perform mainly outpatient surgeries along with endoscopy. So like everyone else, we were very concerned with the stories that were emerging from Italy and elsewhere when COVID started to emerge six months ago at this stage. And a lot of preparations were made across the city. There was inter-hospital collaboration amongst the private sector, that's the Bonds and the Mater Private, with the public hospitals, and also considerable work put in by clinicians, management in all the individual hospitals. I think like every place else, our intensive care physicians were very concerned about the deluge of COVID patients that were going to arrive, and in particular the deluge of sick patients, which thankfully didn't happen too much in Cork. So from a surgical perspective in CUH, we normally have 13 operating theatres, and that dropped down to just 4 in March, around the time of the lockdown. So how did we manage this? Well, we were very lucky that the South Infirmary agreed to take acute trauma and acute plastic surgery. They would traditionally be performed in CUH, and they were transferred to the South Infirmary, which probably saved about 3 operating theatres per day for us. Now, the orthopods and the plastic surgeons do their elective operating in the South Infirmary, so it's an environment they would have been used to anyway. So the rest of us were left to divvy up our surgical practice amongst 4 operating theatres. 1 was left aside for emergencies, and for the elective people, well, essentially we had a daily meeting in CUH. It was usually chaired by Professor Paul Redmond and attended by surgeons who were planning to operate the following day, by various anaesthesia colleagues along with theatre personnel. And essentially the priority was given to time critical surgeries, as you can imagine. To work this, what we often did was ended up combining lists. So you could start with, say, a nephrectomy, then a breast cancer case, and then a neurosurgical case. And there were occasional weekend lists. This happened twice in total. And getting into the nuts and bolts of the issue, if you look at the bottom line there, the second column refers to 2019. The third column is the workload in 2020. And this refers from the 1st of March to the 31st of August in both years. And there's a drop-off of over 900 cases, in fact, nearly 1,000 cases in CUH during that time frame. And that is about 20% of our elective operating. Now, not all the specialties in CUH are covered in this. This is the data that I could get for the purposes of this presentation. Now, looking at that in particular, if you look at general surgery, it's about 14.7%. Now, that would include emergency surgeries as well as colorectal surgery. Whereas if you look at vascular, breast and cardiothoracic surgery, they all dropped their elective activities by about 1/3. Now, next slide, please. Going on to the Mercy University Hospital, again, a similar drop in terms of the absolute number of cases not done between March and August 2020 compared to 2019, over 900 cases. That is about 50% of their workload compared to the previous year. Now, they did outsource some cases to the Mater Private. I believe these were predominantly urology cases. And so, as one manager said, they're doing less currently, although it's costing more. Can you go back, please, 2 slides to the South Infirmary? So, now, next slide, please. So looking at South Infirmary data, there is an incredible amount of data available on the internet in the South Infirmary. And if you just look at the red box, back 1 slide, please. It gives an idea of what happened in April. There was a significant drop off in terms of the elective activity in the hospital. across all specialties. Now, obviously, trauma for orthopedics and plastics increased, but all elective operating was significantly reduced during the COVID lockdown. Now, next slide, please. One set of surgeons that is worthy of comment from Cork, although they're under the auspices of a different Royal College, are the gynaecologists. So they had embarked on a waiting list initiative prior to the COVID onset, and they had reduced their outpatient waiting list from over 5,000 down to 900. But this did have the effect of increasing their inpatient waiting list. It more than doubled to over 1,000 patients. So during the COVID lockdown, they managed to get about 400 inpatient cases performed in the Bon Secours Hospital. This was a combination of 327 cases that were done under the public contract with the HSE and another 86 cases done via the NTPF in July. So that reduced their waiting list very significantly, and I think it's an example of an opportunity that was available to them during COVID, which they took advantage of. Now, of note, CUMH is the only public hospital in the country that is led by a clinician. If you'll indulge me for a minute about breast cancer, which is close to my heart, certainly in CUH, the figures in 2019 are shown in green here and in 2020 in yellow. And there was a drop off in March, April and May. So we've 35 fewer cancers diagnosed this year to date compared to 2019. And it's not clear to us where these cancers have gone to. They certainly don't appear to have gone to the private sector, for example. Now, we're back to normal since June, July and August. So our figures are comparable with the previous year. And what's particularly noteworthy here is our capacity to see patients is down to about 50%. So we're seeing the same number of cancers with seeing far less patients. Next slide, please. So some of you might not be familiar with what's happened in the breast services since the reconfiguration in 2009, and CUH is pretty representative of the rest of the country. Back to the previous slide with the graph. So we have a similar number of cancers being diagnosed year on year, but we're seeing far more patients to diagnose those cancers. So prior to the reconfiguration in 2009, I think a lot of hospitals were seeing 10 breast referrals for every one cancer. In some of the breast units in the country now, they are seeing 40 breast patients for every one cancer. Now that's a situation that's clearly out of control. It is not sustainable. And I would strongly argue that we cannot and should not go back to the situation we were in prior to the onset of COVID. Next slide, please. So challenges in Cork going forward. We're certainly hitting trolleys again, big time in CUH. We don't really know, and we're quite fearful of what's going to happen once the regular influenza season kicks in. There clearly are going to be waiting lists that have emerged both in the private sector and in the public sector with the lack of surgery over the past few months. I don't have data for what went on in the Bon Secours Hospital or the Mater Private in Cork during that time frame. And this undoubtedly is also going to have a big impact in terms of training. In the Mercy University Hospital today, I don't think it's a big secret, there has been an outbreak of COVID and they've had to abandon all elective surgeries today. There has been some COVID cases amongst staff, along with patients, and a huge number of patients and a huge number of staff ended up being tested apparently, resulting in cessation of all elective surgery. So going on to my last slide, the summary slide, please. Overall, I think we handled things reasonably well in Cork, but it's fair to say we were also extremely lucky. We didn't have to deal with the high volume of patients with COVID that our colleagues in Dublin had to deal with, nor did we have the high volume of critically ill patients that overwhelmed intensive care. That did not happen to any of the hospitals in Cork. We did manage to protect our time-critical surgeries, but undoubtedly there are significant challenges ahead. However, I think there's also opportunities to really think about what we're doing in general and to revamp how we change our surgical management of patients, and in particular the outpatient clinic during this time frame. Thank you.
Well, Martin, thank you very much, and thank you for putting so much effort in getting the data together to show us. I mean, some dramatic figures there: 1,000 fewer cases done in University Hospital, and that your numbers of breast cancers presenting are significantly down on what they were last year. And I'm sure that is across the board. That's in colorectal and other cancers as well, that you've seen fewer, that people are being picked up only when grossly symptomatic.
Yes,
and of course, screening has stopped.
I don't have the data for other cancers. And as you say, I was just about to point out that breast check is closed for the past 6 months. So there's been a significant, obviously, there's been a drop off in terms of the screen detected cancers, which is going to have implications down along the line as well, obviously, for the symptomatic service.
I mean, do you have a sense that there is a collective ethos of trying to solve problems without engaging every stakeholder, and that things that good is good enough, and that people are just getting on with things as best they can?
Yes, absolutely. And I think it's been quite remarkable, the effort that everybody has put in, and it certainly helped collegiality quite a bit. I mean, these theatre meetings where you discussed, will your case or my case get in this week? You gave a bit one week, you got a bit the following week. They were never really contentious, and everybody just got on with things.
So the trouble here is COVID fatigue, and how long can we rely on such goodwill? Is there a sense that you get that in Cork that there is this fatigue setting in, particularly if we're facing into seeing the unacceptable challenge of trolleys in ED and on corridors? Yeah,
there's undoubtedly COVID fatigue across the hospital. You can see it in medics, you can see it in nurses. In fact, right. I'm sure it's countrywide, and it's a big problem that's going to face us. And I think we're particularly vulnerable, as you mentioned earlier on, Ronan, in terms of elective surgery being postponed. Now, I think one thing that we're definitely going to make a big effort to try and do in Cork is try and protect the day ward. A lot of our surgeries can be done as day cases, and it would be an absolute disaster for us if day cases, if they took over the day ward for trolleys,
You're very fortunate to have the South Infirmary as an elective only outlet. Do you envisage making more use of that, or is it maxed out?
I can't give you the figures on whether it's maxed out or not, but certainly there were provisionally plans put in place, and they never had to be activated. That say, some CUH surgeries would go to the bonds, some stuff from the South Infirmary and the Mercy would go to the Mater Private. I don't know what the exact capacity is in the South at the moment, but they were able to accommodate trauma from orthopedics and plastic surgery. Now, a lot of that was presumably because the elective orthopedics probably closed down quite dramatically, I'm guessing. So the exact capacity, I doubt they have too much capacity, to be honest.
Well, thanks very much, Martin. Brian Lenihan from UL Hospitals Group. Brian, you have the unenviable task of being the Chief Clinical Director, and I know you're under enormous pressure this week, so we'll be very pleased to hear how you're getting on. Brian, you're muted.
That's it there now, Ronan. Thanks very much for the opportunity to talk. And for full disclosure, I'm a consultant orthopedic surgeon. For those that aren't familiar with the UL Hospital Group, it's essentially we operate as one hospital across 6 sites. So we have our main Model 4 hospital, University Hospital Limerick in Doyle, and then we have St. John's Voluntary Hospital, Croom Orthopedic Hospital, which is our dedicated elective orthopedic hospital, and then we have Nina, Ennis, and the Maternity Hospital Limerick. I think our story very much mirrors what Martin has described in Cork on a number of levels. And like all groups, the initial impact of COVID resulted in a severe curtailment of scheduled care, particularly surgery. We started our programme of resumption of services in earnest in early May, so the 4th of May, with urgent cancer surgery and time-critical non-cancer surgery prioritised. Throughout this time, this really has been hampered by theatre staff being redeployed to support critical care, the emergency department and the inpatient wards. But by the first week in August, we had reached a steady state in scheduled care, while not really getting back to our pre-COVID level of activities. So if you can go on just to the first slide. I think the first slide, it just documents the theatre activity and the theatre lists that are available to us across the group. And you can see from that there's been a 33% decrease in the main theatre lists. Trauma has been essentially maintained because trauma continues despite any pandemic. We've increased the number of emergency theatre sessions per week to cater for the significant number of emergency surgical presentations, and delayed vascular presentations. Acute ischemic and acute and chronic ischemia has been a particular problem. The unit most affected has been Croom Orthopaedic Hospital, our own hospital, and that's been a challenge because of COVID, but also been a challenge because of true and temporary nursing deficits. So that's one of the biggest challenges we face at the moment, is nursing deficits to actually staff our theatres. COVID in itself isn't the biggest challenge. It's staff at this stage. Can we go on to the next slide? If we just delve a little bit deeper into the theatre activities, like you've seen in Cork, we've had a decrease across the board in our scheduled care, so our elective main theatre. Day ward has been significantly impacted. Trauma has increased over the period, and the the number of emergency cases hasn't necessarily increased, but I think the complexity of a number of them have. And ophthalmology, the often forgotten surgical specialty, has seen a significant decrease in its activity. And that's all on a background of growing outpatient and inpatient waiting lists. So if we can move on to the next slide. So overall, when we look at 2020 figures and compare them to the same figures from 2019, we've seen a 34.5% increase in our adult outpatient waiting list. And when I look into that further and I look back to where the waiting list was at pre-COVID, 50% of that increase is related to us not having seen high volume outpatients during the initial phases of lockdown. And can we, next slide? And that's mirrored in our adult inpatient waiting list. Again, 50% of that is entirely related to decreased service provision over the period from the 4th of March until today. The next slide. The next slide, day cases. We've had a significant reduction in the availability of the day ward, and I'll talk just a little bit more about that in a minute, with a significant increase in the day case waiting list. And then the next three, we can just go through them quickly. They reflect the same issue in our paediatric inpatient, outpatient and day case waiting lists. So let me just go through the next three slides one after another. So everything is up across the board. We're uniquely challenged in Limerick in that we have one emergency department for a population of 400,000. And despite the number of COVID positive patients currently admitted in the group lying at only 4, we continue to have significant inpatient capacity challenges. And that's due to a high volume of high acuity patients presenting to our emergency department, with a large number of them being frail elderly patients. So yesterday, despite the Department of Health and the HSE suggesting that there's a decrease in ED attendances, we saw 236 attendances at the ED yesterday, or on Monday, and 234 yesterday, which is significantly above what we would expect in a September of a year, which normally would run in the low 190s. We've resisted to date putting trolleys back on the wards in the context of the fears of COVID transmission, but University Hospital Limerick, like a lot of our other Model 4 hospitals across the country, we've no protected surgical beds, never mind protected surgical scheduled care beds. And like Martin fears in Cork, our day ward de facto is a medical inpatient surge ward, and has been even pre-COVID due to our capacity limitations. What a lot of people mightn't know is that as of tomorrow, all scheduled inpatient care in University Hospital Limerick has been stepped down or cancelled for the remainder of the week due to the capacity challenges. And as a consultant orthopaedic surgeon and the chief clinical director, this wasn't an easy decision for me to make at hospital exec today. But I came on duty this morning with over 100 patients awaiting an inpatient bed at 9 a.m. So that's 100 patients who are in our hospital who do not have a bed on an inpatient ward as we would understand it. So they're bedded in the ED in cubicles, on trolleys in the corridors in the ED, in our medical assessment unit, on beds, trolleys, and indeed on chairs, in our surgical assessment unit, and we have absolutely every bed in the hospital, be it an inpatient bed, a surgical day ward bed, a medical day ward bed full. We have protected capacity in our ICU, and we would have our STEMI bed and our thrombosis bed, but they are the only beds we have available that we can flex. So we're entirely dependent upon discharges, transfers, and everybody putting their shoulder to the grindstone to improve patient flow. For the remainder of the week, all routine outpatient radiology procedures are cancelled to try and facilitate inpatient diagnostics, and all routine outpatients, both medical and surgical, are cancelled until Wednesday of next week. The philosophy behind that is to try and facilitate ward rounding and discharging. It's very hard if you're a physician or a surgeon who's on call today and has a clinic tomorrow to be effective at ward rounding, discharging and transferring if you have to go down to a busy clinic. From my point of view as the Chief Clinical Director, the only way surgery is going to return anywhere to normal within our hospital group is if we do tackle the thorny issue of surgical cohorting, if we do tackle the issue of having protected surgical beds, and far more importantly, the issue of having protected surgical scheduled care beds. And I know this is something that has been discussed at a college level and with the Department of Health and indeed the HSE. But everything I've said for the last few minutes is in the context of not having a high number of COVID positive patients in the hospital and hoping that we don't have a significant increase in COVID-19 admissions. But even without that, at the moment, we're a hospital that's in crisis from a bed capacity issue. That's the report from Limerick.
Well, Brian, all I can say is it's really shocking, and our thanks and sympathies go to you and your colleagues for the work you're doing and the difficulties you're facing. And to come in every day and face that challenge is just sapping, I'm sure. And I'm sure you're finding people are beginning to be burnt out. I certainly found until, fortunately, I retired not so long ago, but I found this coming in every morning to find people on trolleys, not being able to examine them, no decency, no separation. And the first thing that you said to them was to apologize for the conditions in which they found themselves. And I think all of us have been doing that now for far too long. It's all very well for the minister today to be saying that the service needs 2,000 beds. But as a profession, we've been telling them that for years and years and years. And in Limerick, you have suffered more than most, is all I'll say.
Yeah. I think Ronan, we need to as a speciality, I think we need to increase our advocacy for the surgical patient and to try and, even in the context of COVID, ensure there is surgical cohorting and protected surgical beds and scheduled care beds, because the easiest option for me as the Chief Clinical Director when a crisis happens is to cancel scheduled care. And the problem with cancelling scheduled care going forward is these are patients who have waited a long time for their surgery, which may have been cancelled during the peak of the COVID pandemic. And have self-isolated for 14 days in anticipation of their surgery. So I don't think cancelling scheduled care should be the first option always. I think we have to look at better ways to work.
Well, indeed, Brian, the problem is, as you now find as a clinical director, that the easiest, the soft target is always the day ward and the scheduled care. Now, given the figures that you've provided, needs must this week, and you just simply have no alternative. But how many of us over the years have seen our bed quota reduced, and we've been given undertakings that these beds would be protected, and of course, at the first opportunity, that promise has been broken. Have you found Nina, Johns, and Ennis of any value in terms of allowing scheduled care?
So St. John's, or a voluntary hospital, is running a normal theatre schedule, thankfully, which is accessible for the majority of the surgical specialities, but with some reductions in the activity levels there, just with physical and social distancing. Nina and Ennis are predominantly day case surgery units. So all of the surgery that's done there is on a day case basis, and they're running well at about 50% activity. Again, the reason for 50% activity is the true and temporary nursing deficits, which we're working hard to fill. And that would be the main reason for only 4 of 10 scheduled care lists in Croom Orthopaedic Hospital. So yeah, some of it is COVID, but the other parts of it is, the reason we have capacity challenges, just high numbers of attendances and high acuity and frail elderly patients. And we're seeing peak winter levels of presentations in August and September, which is concerning going into a winter which is probably going to be the most challenging winter any of us that are currently working in healthcare have seen.
I see Paul Burke has joined us. Paul, you mentioned that there was, if you like, a Nightingale facility had been built. Has that been of any assistance?
Yeah, we call it the intermediate care facility. It has been of some assistance. We built it for a capacity of about 60 patients. We have used about half of that most of the time. I mean, the patients that have tended to go there are patients whose care has been completed and really are just in a waiting situation in terms of maybe require some a course of rehabilitation, or they're waiting for transfer to a nursing home or some such scenario. But what Brian is really talking about there, unfortunately, are patients who have come in the acute situation. Like, it's interesting, we did talk about it a bit this morning, even at the executive, that one of the issues now in the Midwest is that there has been a very significant reduction, if people have ever followed it from an economics point of view. There's a huge number of GPs of our age, dare I say, Ronan, who have retired in the last 12 months. And a lot of these practices haven't been taken over. And so we're getting an awful lot of people, older people, coming in with acute problems, which do need an acute management in the short term. And if you can imagine it, when you have only one ED for a centralized ED, and you're getting people in from West Clare or from North Tipperary, the problem is, even if they come in, if they come in after 7 or 8 o'clock at night and they live alone, it's very difficult to send them home again. They may not get home until 12 midnight into us. So there tends to be a default approach by the medics to say, look, we'll hang on to you overnight and we'll have another look in the morning, but we think you can go home, but we're not absolutely sure. So that,
I know we've just got a message that my own 89-year-old mother-in-law is being discharged this evening without any information to the family.
Yeah.
It's
just a reality of life. But the problem is that when you've worked with a really small number of beds, and as you know, we're all in the scenarios now bringing in cancer cases on the morning of surgery, etc., and minimizing their time in hospital. Even that type of scenario is just taking that option out. So we were even talking today about that intermediate care facility being used in the short term for transferring those type of patients who we think will probably be able to go home the following day, putting them over in that type of unit almost as a babysitting service overnight. So
I think as surgeons we have paired every time when it was 75-80% of your workload has to be through a day case unit. Well, we've achieved that and more. And then when it is day of admission surgery, we've achieved that. We've actually gone to a point where there is no
more meat on the bone.
Slack. Yeah. There's no more meat on the bone. Brian, can I just ask you about the nursing shortages? That seems to be a really difficult problem for you.
I think when you look into it, it's probably a problem in most groups. You're always going to have true deficits, so nurses who have retired, and then you're always going to have your temporary deficits, your unanticipated sick leave, your maternity leave. But we have a constant, ongoing, rolling recruitment campaign. We seem to just have a pinch point at the moment with some of our theatre staff, and the solution is in place. But as you know yourself, when you recruit, it takes several months to actually fill the post by the time you have gone through all the clearance processes. So there's a clear plan in place for that, but it's acutely problematic at the moment.
Well, thank you, Brian, and thank you, Paul. Maybe Michael Curran will be able to give us some good news from the West. Michael.
Good evening, everyone. President, thank you for asking me. I think I kind of slightly lost the train that you wanted to be. I was very interested in Martin O'Sullivan and Brian's overview in terms of COVID. In preparing this talk, I kind of made it a bit more broad-based rather than pure COVID, functioned on the basis that we live in a relatively COVID-free zone in the west of Ireland. It's probably something to do that the Ceuta region, occupies about a third of the landmass and has a sixth of the population, or maybe it's just naivety on my part and we're going to be snowed under shortly. But COVID obviously hasn't gone away, but it's at this moment in time, there isn't any COVID positive patient, an inpatient in the University Hospital in Galway. And we spent the months of April, May and June, moving all elective surgery off site. And we're pretty much back up to what we'd be like in terms of normal clinical practice, the last few weeks, having taken a bit of time to get there overall. I really don't know what's going to happen. The situation in the west of Ireland in terms of healthcare delivery is far from perfect. And I'm going to give you all my own biases in the next 10 minutes and see what you make of them. So if I could have the next slide, please. So my kind of concept for Irish surgery is that, that it should be divided into emergency, elective and cancer, and that you should have fit for purpose environments across the range for those, so that the cancer centres should probably be in major emergency centres with multidisciplinary working, and elective care should be delivered in fit for purpose centres where whatever it is you're meant to be delivering, you deliver, and it shouldn't be mixed in with the kind of concept where I say to people, it's like somebody going shopping on a Saturday and heading into the library to buy a leg of lamb. So, anyway, and then overall it should be patient-centred, research active, fit for purpose, and regionally appropriate. Like our region has different needs to other parts of the country and so on. And I fully understand that each region has its own issues and important things that need to be delivered. There should be a national training programme which delivers fit for purpose training for the individual regions. And then, as people progress through the system, vision and leadership should be rewarded, and one would hope that surgeons can get into leadership positions and develop coherent strategies for delivery of medical care. And it's very nice to see Brian Lennon here as the clinical director for the Midwest as a surgeon. And it's really important for surgery in general that we interface in the context of the delivery of care overall. Okay, next slide, please. So, right, from the point of view of our region, I suppose you understand the situation. We have the Model 4 hospital that's eccentrically placed. We have 4 Model 3 hospitals, and we have a Model 2 hospital in Roscommon that's kind of integrated with Portiuncula and the region in general, and is functionally very busy. One of the striking things is the number of theatres, which I've brought together here, just trying to figure out how many theatres there are for the number of surgeons. And as I'll show you, there's actually a distinct lack of access to theatre capacity for the region based on the number of active surgeons that we have. Next slide. So then just looking at our own hospital and the number of the total staffing overall, you'd see the vast numbers of surgeons that we have. And what is rather striking is that I can't read my own slides because of the old thing is in the way. The totals down at the end here, which I don't know if anyone can see. We have whatever, I think it's 59. I can't see the whatever the bottom total number of consultant surgeons in our hospital now. And you'd see the number of SPRs at 18 and 35 registrars. Now, one of the things that I find extraordinary is that we have so many non-training registrars in our hospital, and it's mirrored across the region. I find it upsetting that there are so many registrars who are really good, really committed, and in developmental roles within the health service that aren't on training programs. And it's even more upsetting that some of these progress to getting exams and getting onto the specialist register and then take up consultant positions without having the advantage of having come through a training program, which would make them more fit for purpose, because we want them to be teachers, trainers and mentors as they go forward. So, and I do think as a college and as a community, we need to address this as we go. Next slide, please. So this is the same slide looking across Galway University Hospital versus Mayo University Hospital, Sligo University Hospital, Letterkenny and Portiuncula. And what's quite striking is that the number of specialties and academic surgeons, etc., within the university hospital, and then how few surgeons there are in the Model 3 hospitals, having to deliver a very significant workload overall. And there are differences between the hospitals in our region based on the specialties that are active. Next slide, please. So this is a HSE slide, and it looks just at the weighted activity in terms of the activities for Portiuncula, Mayo University Hospital, Sligo University Hospital, Letterkenny University Hospital, and Galway University Hospital from the top down, and then comparisons with the other major teaching hospitals in the region. And you will see that in terms of inpatients, ED presentations, A&E admissions, outpatient activity and day case, Galway University Hospital is arguably the busiest in the country. It's certainly in the top 2 or 3 for everything, but the total numbers. And the next slide, if you look at the weighted activity versus the funding models, I have the weighted activity here and then the funding across the range for the various hospitals, you can see that there's potentially a disparity between the workload and the funding, which is potentially adversely impacting on what's happening in our region. Go on again. So this is a slide. I'm very grateful to Jerry Kelleher from the and Pori Kelly and others who've given me a few slides from the national waiting list. You'll all be aware of the issues around the vast enormity of our inpatient and day case waiting list for the surgical specialties. And this is a terrible denigration of our healthcare system. And you can see here, like the lower green is people waiting less than 3 months. And you can see that there is a rump of that runs across at about the 25,000 level. It dropped due to COVID, and that's probably because people weren't presenting and weren't being put on lists. But you can see that overall, the actual waiting list has increased during COVID, and this is the same across all hospital and all regions. So the next slide. And this is it just in terms of the table of the waiting list. You can see that our region has 21% of those waiting of the total, and you can see that in the context of the country as a whole, that the enormous numbers of people that are waiting for inpatient surgery, and you can see the numbers that are waiting more than 12 months. So that isn't a modern or appropriate healthcare system to be running. And all you have to do is listen to Brian Lenihan and Martin O'Sullivan in terms of what they've said and say, look, at COVID has just made things worse. But I would say to you, things were poor before COVID, and we as a group need to fix it. Go on again. And this is the same. This is the inpatient day case and GI scope list by surgical specialty. And you can see that the big ones, 28,000 waiting general surgery, 10,000 waiting orthopedics, 10,000 waiting urology, and this is derived from the open data published by the NTPF, and this is for surgery treatment per surgical specialty in the country. And go on to next slide, just for our own region. Next slide, please. Sorry. You can see here I've the University Hospital Galway in the bottom and the region on top, and you can see that the big three are orthopedics, ENT, and urology, right, in general for our hospital, and then general surgery is added in for CELTA overall. But there's thousands of patients waiting surgical intervention in our region, and many of them waiting for more than 12 months. Go on again. So one of the things that we've done here, and I've been kind of a real advocate for this for a long time, is to try and separate cancer out. And over the last 12 months, we've developed a system called a Managed Clinical Academic Network, and we've set up two, which will hopefully all of our systems across the region will be managed in this fashion. So we've done for cancer, and I'm the director of this, and John Morrison, my professor of orthopedics, is the women's and children's director, and we've tried to move these out so to try and deliver a group-wide governance structure with a clinically led, professionally managed cancer system in place. Now, trying to do this in the normal scene of things would be okay, but to try to do it in the backdrop of COVID is just extraordinarily difficult because there are so many moving parts. But one of the things that we managed to do, and maybe next slide, when COVID hit, was we actually put in a managed clinical academic network response to COVID, which overarched across the region. We tried to preserve urgent time sensitive surgery, and we successfully did that. We put a double triage process in place with virtual clinics. We added in some new OPD clinics in a new way to move them into a COVID-free environment. We purchased some additional diagnostics and validated waiting lists and tried to run the process in a way that could keep the show on the road. We moved nearly all of the elective cancer surgery to either the Galway Clinic or the Bon Secure here in Galway. And we even had our colleagues in the breast program in Letterkenny come down to perform elective cancer surgery in the Bonds overall. So we were able to deliver that system overall. But of course, that was for the 3 months when the COVID situation was in play. And since things have returned to normal now, but as I've said, we've been running a relatively COVID-free hospital for the last 6 weeks or so. So we've been able to get things back up to what they were like. But some of it is barking mad, right? Some of our cancer-based diagnostics, there's a CT waiting list now of 1,254 patients and an MRI waiting list of 3,246. And this negatively impacts on everything that's done, and also means that almost every patient who's admitted as an emergency will be detained in hospital awaiting their diagnostic CT or MRI, because there's no prospect of them being able to give it in an outpatient setting or acquire it in an outpatient setting. We have several hotspots, including issues around, say, template biopsies for prostate, trus biopsies for prostate, and so on. So it's going to be a real challenge to provide an integrated fit-for-purpose program as we deliver this. But the one thing to say is we've tried to move it into an overall cancer program, and it's a way, it's you know, the challenge is to try and do that in a way that's functional across the region with the help of the hospital managers, etc. So go on again. So, you know, in terms of the KPIs, we've actually largely been able to maintain our KPIs through COVID. We have huge challenges across some of them. Martin will have touched, we've 800 routine waiters in breast program now that haven't been seen since February. Breast Check is shut down. We have a process where it's been very difficult to run the prostate program in a way that's reasonable in terms of time frame, though it's, you know, back up and running to a large extent. And we've done a lot of robotic prostatectomies in the Galway clinic during the COVID scene and continue to do so both here and there now. We've been able to largely maintain our medical oncology monthly key performance indicators across all of the centres through COVID proofing it, but it is challenging. Okay, go on again. So one of the big issues in Galway is that we've a relatively completely unfit for purpose environment, in that our university teaching hospital, or the regional hospital as it was called, was built in 1954, and some of the wards haven't changed much in the last 60 years, and they're certainly utterly un-COVID proofed, with the Nightingale long wards, etc., still in play. We have a Merlin Park hospital that largely was depleted of services and moved on to the university hospital site over the last number of years. And we've got an orthopaedic centre in Merlin Park, which the orthopaedic elective theatres went down in 2.5 years ago and haven't actually been reconditioned. And we've a couple of theatres about to open there sometime in the next 12 months, but there's been we've a huge waiting list in orthopedics, and it's really unfair in terms of the program for the region. And then you know, but we have actually put our heads together at trying to identify the way forward there. We had a university healthcare group output with the South University KPMG commissioned report last year. We're doing the same for the Model 3 hospitals at the moment, and I'm doing one for the cancer program for the region at the moment to address how we can deliver a fit for purpose program with all of the contingencies that have to be put in place currently. So last slide, I think, or thereabouts. Education and research is a fundamental part. Just you'll be aware that we ran the prayer meeting virtually with help from lots of people. We've got a lot of young people coming through every day of the week. I'm completely energized by my contact with young people coming through surgery at undergraduate and postgraduate level. We run a Thought Masters program here at the moment, and it is probably on the greatest upward curve I've seen since I've been here. We had 48 people register last year, and there's 56 this year. It works, I think, in terms of giving people the basics with regard to how to present papers, how to write papers, how to present themselves, how to gather evidence, etc. And you know, there's stuff related to professionalism and so on within the program of surgery overall. One of the things that we've done that I'm the most proud of, I think, is just build the Lamb Institute for Translational Research within the grounds of the university hospital. So in terms of biobanking and cancer care and delivering stuff in that space, we have a process in play that I think will stack up going forward. But our challenge is that we have a huge infrastructure deficit overall. So final slide then. I think, you know, surgery requires a modern infrastructure to deliver complex care. I strongly would suggest that we actually need to separate things out into their component parts, and the component parts are emergency care, cancer program, and elective surgical care, and that we really do need to address that for the country and deliver programs and processes that are fit for purpose. And when people are appointed, they need to be given the tools of the trade. So it's utterly unfair to be appointing young surgeons and not giving them the equivalent of a couple of days a week in the operating room, day case, outpatient facilities especially. And we need to tie in appropriate diagnostics so that when the patients come, they come to a program that can allow them to have their investigations done in a way that's meaningful. Celta is a very large region with complex and predictable issues. I've mentioned some of them this evening, you know, the issues around the complexities of Model 3 versus Model 4 hospitals, surgical staffing, fit for purpose training, integration of undergraduate, postgraduate medical care, and then postgraduate programs, etc. I think surgical training has to take account of the life cycle of surgeons, and our surgical infrastructure has to allow, allow people to progress, like Brian Lennon or Martin O'Sullivan or Paul Burke, etc., and you running into a situation where you can lead, educate, train and mentor people. And this is really difficult in the Model 3 hospitals, which delivers very large components of the care in our region. And we owe it to people within those hospitals to have a more fit for purpose environment. We have to put a regional training program in place that's functional and appropriate. We need to develop the kind of trials networks and the research things that we're doing that will make people working in those hospitals have an ability to be part of something bigger than themselves, and so on. And I just believe that in terms of COVID, look, it's revealed a lot of pre-existing deficits, but I think we need to use it as a means of putting something better in play going forward. And it's a huge challenge for us as a bunch of surgeons to actually be able to integrate the political interface into an appropriate environment that allows us to develop things. And one of the things that I see is very important right now is, you know, we can talk about the last 3 months or we can talk about the next 3 months, but what we actually need to do is to put a fit for purpose environment in play for the next 20 years. And in order to do that, you know, things like COVID or VRE or whatever else will actually shape how we manage things. And all we've, you know, it's important that we work together to put that sort of lasting solution in place for our surgery. Thanks.
Thanks very much, Michael. Really comprehensive review of your difficulties at Celta, and yet you've been relatively COVID-free, and long may that remain, because I think if you got bad COVID numbers into your system, given the very large workload and the waiting list that you have, it will be really, you could decompensate. I like this concept of separating out emergency surgery, scheduled care and cancer care. The difficulty there always will be that the emergent surgery will trump the cancer care, which will trump the scheduled care. But I do see the rationale behind it. In the interest of time, I'm going to ask Mark Taylor to join us. And Mark, you're extremely welcome. I hope the news from north of the border is happier than it is south of the border. For those of you who don't know Mark, he's a HPB surgeon based at the Mater Hospital in Belfast, and he's president-elect for GBNI HPB Association. So Mark, you're very welcome, and we look forward to hearing.
Mr. President, thank you very much indeed. I have two breaking pieces of news. First is Eamon Michael has amazing powers of persuasion, because he phoned me at 5 on Monday and asked me to do this. And number two, with the next slide, please, Pauline, Brexit has just announced the new 50p piece as sterling. Next slide. I hope that over the next 15 minutes, I want to show you that COVID knows no border, and that actually things are very similar. To give you a little bit of background for those that don't know a little bit about the Northern Ireland health system before COVID, I want to look at the whole chestnut of to operate or not operate during COVID, some of the decisions that we're taking at a regional level in Northern Ireland, and then to make you all feel much better about yourselves, to show you the Northern Ireland waiting lists, and to deal with some of the challenges and future planning in light of COVID. Next slide, please. Northern Ireland has a population of just shy of 1.8 million. We are blessed with hospitals, and in fact at one stage we had 17 acute hospitals for 1.8 million of a population. Thankfully, with every review, of which there's been 16 views of our health and social care service, we've managed to whittle down some of those hospitals. We now have 5 major trusts. The biggest trust in Northern Ireland is Belfast in purple, and then we have 4 other trusts: the Western Trust, the Southern Trust, where Mr. Mackle is from, Northern Trust, and the Southeastern Trust. Slide, please. Pre-COVID, we had a major problem, and I'm sure no different to my friends south, and that is we had increased elderly population. We were able to do things with more expensive drugs and more technical abilities. We still had health inequalities, which were very much post-COVID related, and the way we were organised in the north just was not sustainable for the future. Yes, it was back when started the National Health Service, but certainly isn't today. And we have had a major problem with our workforce, which we will come to. Next slide. I was privileged to be part of an external panel reviewing our health and social care in Northern Ireland. This is the Minister at the time, Michelle O'Neill, with the external expert, Professor Raphael Bengoa, and nothing new in terms of what was described about our system in Northern Ireland, that we had too much emphasis in the acute, very little emphasis on primary care and promotion of health prevention, and we were lacking data. Unfortunately, COVID has probably highlighted some of the areas that we were finding. So here we were in February, and suddenly we hear of COVID. I happened to be in China during the time of the first case in Wuhan. People believed that I brought the virus back to transform our health service. I can assure you that was not the case. When we looked at COVID surge, next slide, we became very much aware of the danger, or the perceived danger, of continuing our surgery, whether it be elective or emergency, because of this beast, which we didn't know about, called COVID. Next slide. And this COVID surge work, and I'm grateful to Siobhan Mackay for sending the slides, look, 235 hospitals throughout the world. You can see the distribution. It's lovely to see that Ireland is lit in green. And the demographics, next slide, again showed some of the breakdown of the procedures, emergency versus benign, versus the different subspecialties. Next slide. When this slide came out, we were all aghast at the fact elective surgery could carry a mortality of over 18%. Now, this is a collaborative study. There are obviously flaws in the way these studies are interpreted, but to all of us as surgeons, we thought, oh my goodness, how can we justify the risk of surgery? Because in the past, pre-COVID, risk versus benefit of surgery was an easy balance to have. But when you now put in a mix where there's a mortality of nearly 20% for elective surgery, that stopped us in our tracks. Next slide. And even when we compare major and minor surgery, we were seeing, albeit very small numbers, mortality of 60.4% in minor surgery in those patients who developed COVID, either on the 7 days before or the 30 days after. Next slide, please. So the take-home message from that particular study, which we'll all be familiar with, was there's a high mortality, particularly pulmonary, with COVID, and obviously we've got to raise the bar of surgery that in terms of protecting our patients. We all started to treat the appendicitis with antibiotics, not consider cholecystectomy in the acute setting, and all of those range of things to try and dampen down. And then we particularly got alarmed, next slide, when obviously all came together to try and look at sort of algorithm of what we should do. And this caused both celebration and dismay, because suddenly we were trying to offer guidance to all of the surgeons up and down the country And yet we were seeing things around laparoscopy is not good. This aerosol generation, we're not familiar with the type of PPE that you should have. Planned surgery has great risks with it. And so we entered a period of very difficult time. Next slide. From the regional decisions in Northern Ireland, there were some very odd decisions. This is the Belfast City Hospital, the big yellow block. This is the Mater Hospital where I'm living at the present. They are two major elective centres in the centre of Belfast. The other two hospitals in Belfast are Musgrave Park, an elective orthopaedic centre, and the Royal Victoria Hospital, the major trauma centre. And what actually happened was that the decisions were made to make the Mater Hospital the COVID centre, and that was fine. So we moved a hepatobiliary surgical team out for a weekend. One of the previous speakers, I think Brian, was saying it's amazing how quickly we can turn around things when we have to. So a major hepatobiliary service moved out of the Mater to make it a COVID centre. And a regional decision was to turn City Hospital, the only other elective cancer surgical centre in Belfast, into the regional Nightingale. And therefore, in one fell swoop, the elective capabilities of Belfast were plummeted by the regional decisions, and that caused immense problems of trying to even do the college prioritisation, emergency, urgent cancer work, all within the trauma centre in the Royal. And to add to this, for Brian's benefit, Musgrave Park staff were all redeployed to other Gs within Belfast. So within one fell swoop, the orthopaedic capabilities also finished. Next slide. And when we looked at the summary from COVID surge, it became clear that cancellations were going to be a major thing for this pandemic, and we had to accept them. Next slide. The prediction was that we were going to see 28.4 million operations cancelled during the 12-week peak of this pandemic, and with all of the implications of that. Next slide. It's been absolutely brilliant to hear Martin, Michael and Brian present the wait times for the rest of Ireland. As Crocodile Dundee said, that's not a waiting list. Let me show you a waiting list. Next slide. So in Northern Ireland, this is pre-COVID, December 2019, day case and inpatient record. This is on public domain. From the end of December, the total number of people waiting for a procedure, inpatient or day case, was 90,514. 27,000 of those were waiting over 52 weeks, and that includes ENT, orthopaedics, general surgery and neurology, a similar theme. Now, when the people of the rest of the UK look at our figures, they say, oh, they're terrible. What they don't realise is they're actually worse than they believe. In England, when they look at waiting lists, they look at waitings from the time of general practitioner referral to definitive treatment. That's not what we do in Northern Ireland. In Northern Ireland, we have a time from the general practitioner referral to see the consultant, and the time from when the consultant sees to the treatment option. And what you're looking at today is when the consultant sees to the treatment option. They're hidden figures because it is also the fact that you could wait more than a year to see me for your gallbladder problem or whatever. Next slide. So clearly what happened at the start of COVID, figures went up to 30,714 people waiting more than 52 weeks. Very similar to our colleagues throughout the country, there was a massive downturn in elective activity, those fear factors for capability, capacity and manpower planning. Surgeons were deployed to intensive care units. Our minister at that stage was predicting mortality, biblical proportions, with an estimate of 15,000 deaths associated with COVID. And it is thankful in many ways that we never saw anything close to that in terms of COVID. Next slide. However, it had a damaging effect. This is the end of June as we came into that lag phase of the end of the first peak. We were seeing that up to 38,314 people were now waiting more than 52 weeks. This would bring government down in the rest of the UK, if that was the current waiting list. Next slide, please. So we had our challenges. We had our challenges before and we have our challenges now. And the difficulty that we have as we are now trying to bring about the restoration of surgery. We were using the college prioritisation lists to look at category 2 surgery. We had regional variation. Not all hospitals had design tools. We also had difficulty in that although we'd gone the independent sector, private hospitals, those hospitals were only good for day case or ambulatory. We don't have critical care units attached to private hospitals in Northern Ireland, and so they were okay for elective breast, they were okay for endocrine surgery, but they weren't any good for major liver, cardiothoracic type surgery. We also have an issue with the perception of PE, and there was a degree of confusion at the very start of the pandemic, and confusion thankfully settled. I should note that our supplies were very good. We didn't have logistical difficulties obtaining PPE. Testing, I think, similar to the rest of the country, started off at a very slow pace and quickly picked up. There was also fear among staff, fear among patients, and we saw a massive reduction in red flag referrals. We saw a reduction in unscheduled care, and we saw a reduction in people who just did not want to come to hospital, even if it was a cancer diagnosis and they were having surgery. So great variation up and down the country, and we also had some difficulties with primary care, and our primary care colleagues had to really set up these COVID centres, which were a place to take patients away from the footfall going into the normal general practitioner, and one of the difficulties was trying to man both their primary care facility and these COVID centres. What has actually happened in all of this is that it has caused a massive degree of inefficiency in our system. Very similar to my colleagues in the south, we have tired, fatigued colleagues of medical and nursing background, but we also have accepted inefficiency. It was very easy to turn off the machinery of acute, elective and cancer care. It's dreadfully difficult to turn it back on. And one of the difficulties we have as we speak today is we have 129 new cases of COVID diagnosed today. We have 2 deaths and 3 in intensive care. And so we are now starting to see the rise. We had a lag phase where it was the young. It didn't transmit into hospital admission, but we're now starting to see that go up again. Next slide. So how do we look to the future? Well, this is press the next button. Thanks, Pauline. This is a little note that has come for hospital meetings. As you know, in the north, we have no money for our healthcare. The Barnett consequentials don't quite stretch to cover all of health. And so from now on, we have to bring our own cup for every meeting. Next slide. No one said what size the cup was, and therefore the trust were providing the tea and coffee, but we brought our own cup to maximise our potential. So thinking outside the box for COVID, next slide please. One of the things we're trying to push in the north here is this concept of COVID light centres. It's been rehearsed by all of our groups. We have an elective care plan in Northern Ireland, which was at long last separate elective surgical care from the rigor of unscheduled care, because unscheduled care is the only show in town. The targets of 12 hours are recordable, and at all opportunities the elective cases take the hit. So to have the COVID light centres with regular staff and patient testing, and the colleges have provided great assistance and given guidance as to when it's right test. Obviously NICE have updated the whole issue of shielding. We do believe you need an adequate source PPE, and what we're trying to push in the north is that rather than 5 trusts trying to work out the solution, that we as a region work out a solution. Clearly the best day coming will be if a vaccine becomes here. Robust data is what we need, and we have had a lot of smoking mirrors for many years in Northern Ireland as to what the exact data is for activity up and down the country. And this webinar is a great example where we can learn from elsewhere. The COVID knows no border. I've thoroughly enjoyed listening to my colleagues up and down the country. But I'm going to leave one final slide. Next slide. How do we deal with this COVID? COVID is here, it's here to stay. And a bit like this old sign that I often like about life, it's not about waiting for the storm to pass, it's about learning to dance in the rain. And I think what we have to do as a community of surgeons is learn to dance around the issue of COVID, the clusters, the increased frequency, and actually work out a way of continuing elective surgery, because we don't have a choice. We have got to look after our patients. If we don't deal with electively, they bounce back to emergencies, they overflow inflow, as Brian said about the Limerick situation at present. So we have really got to dance in the rain. Thank you, Mr. President.
Well, Mark, I think if there was applause audible, as you'd be getting a round of applause. Thank you so much. And thank you, Eamon, for your powers of persuasion. I think Mark is going to find himself imposed upon more than once in the next year for contributions. I think the message is clear. All politics are local, and we simply must use the data that we now have to make public opinion drive political discussion. And for surgery, and it's come up on the meeting chat, for surgery, the only solution is to separate out scheduled care from emergency care. And whether you include cancer in that scheduled care or not is a matter of debate. And that means standalone scheduled care facilities. And you alluded to that, Mark. What is the planning in Northern Ireland for that?
So presently, some of smaller hospitals were piloted to do cataract and varicose vein surgery. They were piloted around cataract and varicose vein at that stage, but there was a large waiting list, and also it was a controlled group that we could deal with regionally. So 3 of the smaller hospitals basically took on those 2 pilots. Recently, the Minister has announced that Lagan Valley, which is akin to the Southeastern Trust in Belfast, is going to become a sort of regional elective care centre. And then we also had a closure of a district general hospital in Omagh, but creation of what was called a primary care and community complex. So there were 3 theatres in there, but all of the GPs were in-house. They had access to CT and ultrasound. Everyone was hot desking, and the clinicians came from the feeding big hospital. So the future, certainly for us in terms of ambulatory, will be these standalone centres, elective care with 24-hour stay centres, ultimately then trying to redistribute the more complex surgery. Thankfully, we have had a degree of centralisation. When I first came back from Edinburgh, we had 6 centres doing Whipples, 3 of which did 1 per year. We only have 1 centre now, and we've managed by one way or another to centralise some of the more complex surgery into high volume single centres. So we're by no means there. We still have all of the difficulties around politics of hospitals and identity of hospitals at every part of the island, but certainly we're making some progress.
Well, I think, Mark, can I thank you again? I think that, as you say, the issues are the same. The numbers are simply frightening. Can I particularly thank Martin O'Sullivan, Brian Lenihan, and Michael Caron, and our support for you in Limerick for your very difficult challenges that you faced this week. My suggestion is that you get Jackie Healy-Ray to get a few buses and send them up to Galway, because they've got no COVID in Galway and they'll be able to look after them. But on that note, can I thank you all, and we will have another, I don't think we'll be doing COVID next week, Kieran. I think we're on orthopedics next week, and we look forward to meeting as many of you as possible online. So good night, keep safe, and thank you so much.